So good afternoon, everybody. Thanks, sir and madam, for giving the opportunity to speak today. Before we move to the panel, I have two important papers to discuss which explore the therapeutic options for treatment of HER2-positive MBC. So this is the first retrospective paper from France, which looks into the role of combination of oral etoposide and trastuzumab for HER2-positive MBC. So as we can see, as we know already that oral etoposide has led to encouraging responses in ovarian cancer, and it's an inhibitor of topoisomerase 2. It has demonstrated good clinical activity in probably heavily pre-treated patients with HER2-negative MBC compared to other active chemotherapies that we use like capibine, paclitaxel, eribulin or anthracyclines. So though we do not see in the guidelines, but it was thought that the use of oral etoposide could be relevant in heavily pre-treated MBC with the advantage of number one, oral administration, low cost, and also manageable toxicity profile. So what was the background was that both the top 2A genes and HER2 genes were co-amplified in about 40% of HER2-positive MBCs. And oral etoposide, as we know, an inhibitor of topoisomerase 2, had demonstrated some clinical activity in MBC. But this combination was not being evaluated earlier. So the primary objective was to evaluate the progression-free survival in HER2-positive MBC. The PFS was defined as period from the initiation of combination therapy to disease progression or death for any cause, whichever came first. And there were a whole lot of secondary objectives which included the overall survival, PFS, under the prior treatment line, response rates, clinical benefit, toxicity, and predictive value of this co-amplification of TOP2 and HER2. So the overall survival as expected was calculated from the start of treatment until death from any cause or until the last date the patient was known to be alive. So the response rates was measured as a ratio of patients experiencing a partial or a complete response using the RECIST criteria, considering patients who had measurable levels of disease at the treatment start. So most importantly, the clinical benefit was seen at 6 months to 24 weeks, and it was defined as a PFS more than 24 weeks or objective tumor response. And the toxicities, as usual, were classified according to the version 5. So this was actually the baseline demographics. Most important to see that 80% of the patients had actually visceral metastasis, and the median number of prior treatment lines were 6. So this is what the patients were heavily treated. And it was basically 43 patients were included. They received the etoposide and trastuzumab combination after a median of 6 prior treatment lines. Median PFS was 2.9 months and overall survival was 11.3 months. 3 patients had a complete response and 30% actually had a clinical benefit. Only 3 patients actually stopped the treatment because of toxicity, and 35% actually displayed a co-amplification of TOP2A and HER2. However, no statistically significant correlation was found between the outcomes and the HER2 and the TOP2A co-amplification. So as we can see, the median PFS 2.9 months, median overall survival 11.3 months with a combination, and the 24 weeks clinical benefit was to the tune of 30%. 30% of patients had responded in the form of either a complete or a partial response. So also when we come to the toxicities, only 3 patients had to stop the oral etoposide because of toxicity. So that was the grade 3 nausea in 2 and neutropenia in 1 patient. But however, when we see there was no difference in PFS based on the co-amplification status. So to conclude, this retrospective study is a hint of activity, and it suggests the use of oral etoposide and trastuzumab, which can be considered as a treatment option in heavily pre-treated HER2-positive MBC patients. The combination yielded some modest and prolonged responses in some patients. And as we know that etoposide is quite manageable with the advantage of oral administration, limited cost, and also acceptable toxicity. So my second abstract was presented in ESMO Congress. It's basically looking at the reporting of the final overall survival of abemaciclib plus trastuzumab plus minus fulvestrant versus trastuzumab plus standard chemotherapy in patients with triple positive advanced breast cancer. That was the Monarch HER. It was a randomized open label phase 2 trial. As we know, the Monarch 2 earlier had shown a significant improvement in overall survival for the combination of CDK4/6 inhibitors abemaciclib with fulvestrant compared to fulvestrant alone as second line for triple positive ABC. Monarch had shown improved PFS when abemaciclib was combined with fulvestrant and trastuzumab compared to trastuzumab plus standard care of chemotherapy. So the final OS and also the exploratory analysis of tumor intrinsic subtypes is also being reported in this abstract. So this was the study design. Hormone positive, HER2 positive advanced breast cancer who had received more than or equal to 2 prior HER2 directed therapies. They were allowed to be having a prior TDM1 and taxanes, randomized 1:1:1 into 3 arms. Arm A had abemaciclib, trastuzumab and fulvestrant. Arm B had abemaciclib and trastuzumab, and the arm C was trastuzumab and investigator's choice chemotherapy. So it enrolled from May 2016 to Feb 2018 in 75 centers from 14 countries. So as we can see, there was a numerical increase in overall survival, 20.7 months in the chemotherapy plus trastuzumab, that's a blue color. And when we go up, it was 29.2 months, and it was 31.1 months best with the combination of the red one, abemaciclib, trastuzumab and fulvestrant. The subgroup analysis, there was a consistent overall survival benefit which was observed with the pooled abemaciclib arms across all the pre-specified subgroups, even in patients who had received prior HER2-directed therapies and also who had multiple organs involved and also visceral metastasis. So when we come to the safety profile of the triple therapy, we find that as expected, abemaciclib grade 3 diarrhea was there in 9% of patients in arm A and arm B, and when we come to the chemotherapy arm, neutropenia was seen in 24%. So, however, when the exploratory RNA sequencing analysis was done, according to the intrinsic subtypes, it was found that luminal subtypes were associated with longer PFS and overall survival compared to the non-luminal. So to conclude, abemaciclib plus trastuzumab plus minus fulvestrant numerically improved overall survival in women with hormone positive, HER2 positive ABC compared to the standard of choice chemotherapy plus trastuzumab. The safety profile, as we thought was consistent, which was known already for abemaciclib and was considered tolerable. And in an exploratory analysis, the luminal subtypes were associated with longer PFS and OS compared to the non-luminal subtypes. Thank you.